Okay, so we are continuing on with our hypaxial muscles, but now instead of looking at the abdominal pelvic cavity, we're now looking up at the thoracic cavity, but also the muscles that are going to be assisting with respiration. So if we're following along in Lab 5 and looking at our muscle charts, the fifth muscle in this group is kind of an oddball. Okay, so I would go ahead and put a little asterisk next to it, and we'll come back to it. But again, the reason that all of these are grouped together is because they are assisting with respiration. Okay, so our first muscle that we'll introduce is the diaphragm, and this is the major muscle of respiration. All right, so the diaphragm is actually going to be a border between the thoracic cage and the abdomen, the thoracic cavity and the abdominal cavity. So we can see that it makes a dome shape. All right, we can see that it's kind of domed. And if we kind of like stuck our hand underneath that rib cage, we could kind of feel around underneath the diaphragm, and it would kind of be like a cave or like an umbrella almost. All right. Now we can see this inferior view, which is pretty cool. We can see that there are some openings, there's some foramens, some holes, right, to allow for the inferior vena cava as well as the esophagus. But it does kind of give you a good view of the origins and insertions for this muscle. All right, so let's talk about where it connects. All right. So for the origin, there's a bunch of different spots because it is going to originate all around the thoracic cage as well onto the vertebral column. So it originates at the xiphoid process of the sternum, which we can see here. It also can originate at the costal cartilage of some of these ribs. It can also originate on the actual ribs themselves, 7 through 12, lumbar vertebrae, and then also the intervertebral discs of these vertebrae. Okay, where it that's where it all originates, right? But where it actually inserts, if it's originating all around this entire circle, the insertion is going to be in the center of the circle. And the insertion is actually this central tendon. Okay, and you can kind of see that in the superior view of the diaphragm as well. So the central tendon is the insertion. All right. So the action of this muscle. Now, because it is a dome, that is how it's shaped when it's relaxed. When it contracts, it's contracting, and this is the insertion, so it's going to be pulling here, right? If we're looking at this origin point, it's going to be pulling in this direction. If we're looking at this origin point, it's going to be pulling in that direction, okay? So what actually happens is this dome becomes flattened, all right? It'll be just flat at the bottom of the thoracic cage. So when it contracts, it becomes flat. That basically allows for a lot of an increase in volume in the thoracic cage. So this is going to be horrible, but we'll do it anyways. Do, do, do. Oh, it really wasn't that bad. Okay. So here is my thoracic cage with my sternum, and then we've got a bunch of ribs, and I'm not going to take my time drawing those ribs. Okay, so when it does contract, the diaphragm itself will now be flat. So now we have all of this space. Our lungs have increased their volume, right? Here, there was only so much volume for our lungs, but now we've increased and now we have all of this space. So the volume increases in our lungs, which in turn has an inverse relationship with the pressure. So the pressure in our lungs decreases, and then air from the atmosphere is able to flow into the lungs. So because the diaphragm contracts, volume increases, pressure decreases, and we have flow of air into the lungs. That is called inhalation. All right. So that is the action of the diaphragm. That's why it is the major muscle of respiration, because it is controlling the volume within the lungs, and so it results in the ability for air to enter our body, and therefore we have inhalation. All right. Now, the diaphragm is innervated by a nerve called the phrenic nerve, and we'll talk about that more. But the phrenic nerve is part of the cervical plexus off the spinal cord, and this is the only muscle that the phrenic nerve is going to be innervating that you need to know about. Okay, so phrenic nerve, diaphragm, phrenic nerve, diaphragm. All right, that comes up a lot. All right, so let's just think about inhaling and exhaling, because that is respiration, right? So inhaling, air is going to be entering our lungs. Exhaling, air is going to be leaving our lungs. Now, inspiration is another word that we use for air entering our lungs, okay? And we can have quiet inspiration or forced inspiration. Same with expiration. Expiration is is another way of describing air leaving our lungs. So it can be quiet or it can be forced. Quiet is just you sitting there, taking notes, listening, whatever you're doing. You're not even thinking about breathing, it's just happening. Okay, that's quiet. It could be quiet expiration, quiet inspiration. Forced is when I say, take a deep breath, or the doctor or whoever says, take a deep breath, and you, that was a forced inspiration. And then let it all go. That's forced expiration. All right. So, in a normal inhalation, normal breath, quiet inspiration, the diaphragm and the muscle external intercostal are going to be used. Okay. Normal, quiet inspiration. For normal, quiet expiration, no muscles are used. When we just breathe out without thinking about anything, just sitting there and you're just breathing, the exhale, no muscles are contracted to release air. It's just all of the other muscles, the diaphragm and the external intercostals, relaxing. And so air is just pushed out of the body because those muscles go back to normal. Okay. So when we talk about expiration and muscles that are going to allow air to, expel our body, it's always going to be forced, because in normal, in quiet expiration, no muscles are being used. All right. So, diaphragm again is the major. If we want to actually view the external intercostal muscles and the internal costal muscles, we do have to remove the pectoralis major and minor, which major is here. And then if we were to remove that, minor would be underneath. And then also the serratus anterior, which we can kind of see down here, as well as here. You can see it's kind of like serrated appearance, kind of like it looks like a rake or something, like the bottom part of a rake. That's the serratus anterior. So we got to remove those muscles, and then we can have full view of our ribs, except here in this image, the serratus anterior is still there, because again, you can see here and there, it kind of sits posteriorly and then kind of connects onto those ribs. So we can still see that muscle. So it is kind of blocking our view a little bit, but that's okay. All right. So the external intercostal muscle, cool thing to recognize right off the bat is the way that the fibers are moving. Okay. External intercostal, the fibers are going to move in the same direction as the external obliques. And if you remember the little trick of how we remember that direction of fibers, we move from X to sex, right? So X to pointing medially and inferiorly towards our sex organs. So X to sex. So those muscles are going to be, those fibers are running in the same direction. All right. Now, the thing about intercostal, and same with internal intercostal, really what we're just saying is inter meaning in between and costals meaning the ribs. So we're just looking at muscles in between the ribs. One is on the outside, one's on the inside. Internals on the inside, externals on the outside. Okay. So we've noticed the fiber direction for external intercostal. Let's look at the fiber direction for internal intercostal. It's going in the opposite direction as the external intercostals, which was really similar when we were looking at the obliques. So the same little trick, we're going in towards the chin. All right, into the chin is for the internal intercostals. Okay. All right. So both of these muscles are going to be obviously in between the ribs. When we look at the origin for these muscles, it's kind of tricky, especially the way that it's written in the lab manual. So you can read through that description in the lab manual, see if you like it. I'm going to also give a description. Okay. So for the origin, all right, let's just look at this little muscle right here, this one external intercostal, okay? It is going to originate on the inferior border of rib 1, okay? It originates on the inferior border, all right? That means, and especially because it's moving X to sex, right? The insertion is going to be on the superior border of rib 2. So the inferior border of the top rib and the superior border of the bottom rib. All right. So it's originating here superiorly and inserting down here on that inferior rib. So because it's inserting at the top of that rib, though, when this little tiny muscle contracts, it's going to actually pull rib 2 kind of superiorly, right? It's going to pull it so that it moves upwards. All right. And that's how we get the action of elevating the rib cage, because we are inserting on the superior portion of that inferior rib. And so when this little muscle contracts, the rib is pulled superiorly. All right. And so it's the same with the internal costals. That origin is going to be oh my goodness, sorry, little brain delay there. Okay. The origin is going to be along the superior border of the rib, and then it's going to insert at the inferior border of the top rib. And so when it contracts, it's going to pull the muscle in that direction. It's going to pull the rib in that direction. It's going to pull the rib inferiorly, depressing the rib. Okay, so it's kind of the opposite. Here, we're originating on the superior rib, but inferior border. Here, we're originating on the inferior rib and the superior border. All right. So that's what that description in the lab manual is trying to say. And so the insertion, same as origin. So you can put that into your own words, or if how it reads in the lab manual works for you, go for it. All right. But again, because of that varying where it's inserting or originating on these rib borders, it will result in either depressing or elevating the rib cage. Now, if we're elevating the rib cage, that's going to increase the volume because it gives more space for the lungs to expand, and that means we can breathe in. But it's only for normal or quiet inspiration. When we depress the rib cage, we're decreasing the volume, which means ribs or air is going to be expelled out of the body. But remember, air is only leaving the body with the use of muscles if it's forced expiration. If it was quiet expiration, it would be no muscles are contracting. All right. Now, for both of these muscles, they're going to be innervated by something called the intercostal nerves. These are like branches off of the thoracic ventral rami of the spinal nerves. So if it were me, I would just memorize intercostal nerves because it flows with the names of the muscle, and that's totally appropriate because that is true. But if you wanted a full or complete innervation, it would be the intercostal nerves of the thoracic ventral rami of the spinal nerves. But that's a mouthful, so make it easier on yourself. Intercostal nerves, okay? Now, we also have the transverse thoracis. So this is a transverse muscle that's in the thoracic cavity, okay? And we can see that it's in the thoracic cavity because it's obviously attaching to the ribs, all right? We do have the transverse abdominis, right? That was in the abdominal cavity, okay? So do not get those mixed up. So transverse thoracis, right? So it's originating on the posterior surface of the sternum. The sternum is sort of like the ilium of the pelvic girdle. These are bones that we know are not going to move, so they make really good origin points. All right, if you've noticed so far, we've had a lot of iliac crests as our origin points. So the posterior surface of the sternum is the transverse thoracis origin point. The insertion is going to be along the costal cartilages, specifically ribs 2 through 6. So not the first and not the seventh of the true ribs. So you can remember it's like true ribs, but -1 and -7. Okay, true ribs, but -1, -7. And it's only inserting at that costal cartilage, right? Now, the transverse thoracis, this is also going to be assisting in forced exhalation. Okay, so quiet exhalation, no muscles. Forced exhalation, breathe out, expel all the air in your body right now. We are using the transverse thoracis and the internal intercostals. Okay, transverse thoracis is also going to be innervated by the intercostal nerves. So those intercostal muscles plus this one innervated by the intercostal nerves. Okay, so there are some commonalities here, right? Especially with the intercostals and how they're attached. And then, of course, relating their fiber directions toward with the oblique muscles as well. Again, all of these muscles are assisting in respiration, which leads us to the scalenes. Now, the scalenes does have 3 different muscles. I'm not going to test you on them, okay? The scalenes is not a hypaxal, okay? It is not a hypaxal muscle. But we group it with the other hypaxal muscles of the thoracic body wall because the scalenes does assist in respiration. Okay, to find the scalenes, you do have to get rid of the sternocleidomastoid. The sternocleidomastoid is my favorite muscle. I don't know why, just is. You'll have your favorites, okay? So the sternocleidomastoid, we have to remove that. So I crossed it off, and then we can see our scalenes. And again, there are 3 different. We only need to know the one. So the scalenes is going to be originating on the transverse processes of the cervical vertebrae, so we can actually see that there. So because of their origin, we can kind of have some inclination that maybe an action is going to have something to do with the neck. Okay, but also remember, this is being used in respiration as well. And we can see that the insertions will be on the ribs. So that makes sense that they're going to insert on the superior portions of the ribs because it's going to be assisting in deep inhalation. So if this is the insertion and this muscle contracts, it's going to shorten, which means this rib is going to move that way, and this rib is going to move this way. So it's going to elevate the rib cage, which means we have more volume, which means air can come in, so we can have a nice deep inhalation. All right, nice and deep inhalation. So that would be the action. But again, because it does have that origin point and its location towards the neck, it does also laterally flex and rotate the head. All right, so it is assisting in movement of the neck. And the innervation is different for this muscle, but it kind of makes sense because, again, it's originating on the cervical vertebrae, so it's the cervical spinal nerves that are going to be innervating it. All right, so it's a weird one. It's not hypaxial. It's hardly in the thoracic cage, right? It does insert on the ribs, so it is kind of part of it, but it's really only grouped there because it does elevate the rib cage, allowing for deep inhalation. So it is a muscle of respiration. And again, sorry, because it's inserting on the superior edge of the ribs, right? If we come back and recognize the external intercostals, they were also inserting on the superior portion of the ribs, which again is going to elevate the rib cage to again help with inspiration. Okay.